Good morning, everybody. My name is Zahrae Sandouk. I'm a clinical assistant professor at University of Michigan and from the adult endocrinology department. And I would like to thank you for coming today. I will be presenting to you cystic fibrosis related diabetes prognosis. So let's start with talking about some background information. So cystic fibrosis-related diabetes, or CFRD, is actually one of the most common complications in patients with CF, in adult patients with CF. It occurs in at least 40 to 50% of adults, and it is worse in those who have more severe genotype. Like with other forms of diabetes, microvascular and macrovascular disease are the most common causes of morbidity and mortality. And these occur in CFRD, but microvascular disease remains rare, and I will be addressing these in details. There are also some CFRD-specific complications that have more impact on our patients and on their prognosis. And I will also finally talk about how CFTR modulators have revolutionized the care of CF patients and how they have affected prognosis. The complications are typically seen in type 1 and type 2 diabetes. Those are macrovascular complications, so complications of the large vessels, and microvascular complications such as neuropathy, nephropathy, retinopathy, and autonomic dysfunction. So for the large vessel disease, so the most common cause of death in type 1 and type 2 diabetes is cardiovascular disease. The WHO published data in 2016, and it showed that diabetes was the 7th leading cause of death in the US. In contrast, our patients with CFRD are actually more likely to die from pulmonary complications because macrovascular disease or cardiovascular disease remains rare in our patients. So far, we don't have any reports of death from atherosclerotic disease, even though we have patients that are living now into their 50s and 60s. One of the major thought is that these patients tend to have very low cholesterol levels, and which is likely protective. However, we're also reporting and we're working on publishing a handful of non-fatal MI in patients, and things may be changing in the future, and I will be addressing this a little bit later as well. But overall, screening is only recommended for certain patients. So blood pressure is recommended at every visit. And however, when it comes to annual lipid, it's only recommended for those with CFRD and pancreatic insufficiency, or those who have high risk factors, such as obesity, family history of coronary artery disease, and immunosuppressive therapy. Let's talk about microvascular complications now. These can actually occur more after 10 years of having diabetes, and they're reported to be not as common or as severe as in other diabetes. They actually start when looking at patients who have had diabetes for 10 years. They've actually noted that it started when fasting hyperglycemia occurred, and they overall contribute to worsening health outcomes in adults with CFRD. So we're talking here about microalbuminuria, reported to be prevalent approximately 15% of patients, but proteinuria or severe nephropathy remains rare. We're talking about retinopathy, as well reported in around 15% of patients, and blindness remains rare as well in our patients. Now, when it comes to gastroparesis, it's been reported in 50% of patients. So it's quite common, but it's also common in patients with CF without diabetes. So the thought is, could this actually be related to the underlying CF condition and not necessarily just diabetes? Same goes for neuropathy. It's actually reported in 55% of patients, but also in those who do not have diabetes, they also experience symptoms such as tingling more than pain, and they also have some characteristics toes that can be resembling diabetic feet. So the recommendations for screening are to start annual screening after 5 years of diagnosis of CFRD and fasting hyperglycemia. This includes annual eye exam, urine albumin creatinine ratio, electrolytes and kidney function tests, foot exam, as well as neurologic assessment if indicated by symptoms. So screening remains very important because early diagnosis can help with preventing it from progressing any worse. And in fact, the data from other forms of diabetes showed that early treatment intensification also helps reduce the onset and the progression. And we think that the same applies for our patient with CFRD. So now let's change gear to complications that are unique to diabetes in patients with CF. We will talk about how CFRD affects survival from lung disease, how it leads to lung function decline, it leads to impaired nutritional status, as well as affects transplant prognosis. Talking about survival, the negative impact of CFRD is actually very well established. There is a greater mortality in individuals with CFRD compared to CF without diabetes. And there was a very nice study done at the University of Minnesota that looked at this specific thing, at mortality in a patient with CFRD, comparing it to those without CF. And they looked at this by different periods, and they compared men versus women, as well as various genotypes. So I just summarized the results in this slide in chronologic order, basically. So if you look between 1992 and 1997, the mortality was 13.4 times higher in patients with CFRD. So that's quite significant. It was actually found to be worse in women during that period of time. And then between 1998 and 2002, the mortality went down to 9 times higher. So it improved, but the greatest improvement was seen in younger patients and men. And finally, between 2002 and 2008, mortality was 3.5 times higher. And then 2008 and 2012, mortality was again 3.5 times higher. So the difference improved over time, but it did not disappear entirely. We do not have similar data past 2012. So these are this is from the same study looking at severity mortality over time by gender. And you can see this is also by age groups. And you have here on the y-axis mortality by age decade per 100% years. So the dotted lines are the patients without diabetes. Straight lines are the ones with diabetes. Red is for female, blue is for male. And as you can see over the periods, the difference between diabetes, not diabetic, and diabetes has decreases over time. And then you also can see how women were more likely, had a higher mortality rate compared to men. This is again from the same similar study looking at Kaplan-Meier survival curves for adult CF patients aged 20 and older during the latest period of 2008 and 2012. And they divided into 3 groups: those with mild genotypes, the male with severe genotype, and female with severe genotype. And as you can see, that the female with severe genotype were more likely to die or had a lower proportion of surviving compared to those with severe genotype that are male and those with mild genotype. And you can see on the second slide as well, on the second figure, that when it comes to proportion without CFRD, it was actually much lower in those with severe genotypes. So you're more likely to have the diabetes in women with severe genotypes as opposed to male with severe genotypes as opposed to mild genotype. And in fact, the interesting part is after about 30 years of age, that's where the differences were more pronounced and the severe genotypes were associated with greater mortality. So this was actually increased in each genotype category. And you can see that it was 20 versus 2% for mild genotypes versus 12 versus 4% for severe genotypes. So the decline over the years in mortality was attributed to increased oral glucose tolerance test screening and perhaps earlier diagnosis and more aggressive treatment with insulin. But this has stalled. And so the question is, do we need a different approach to improve this? And could new CFTR modulator medications have an impact on this? What is interesting is we actually don't have this specific data past 2012. And in fact, that's around the time when CFTR modulators were introduced into our CF patients. And so it would be very interesting to see results now. Let's talk now about how it affects lung function. So it is well established that CFRD accelerates the decline in lung function. The proportion of patients with low FEV1 is actually high in all age groups with CFRD. The degree of lung function loss is around 0.85 and 2% of the predicted FEV1 per year. It actually starts even or becomes more accelerated even 4 years before the diagnosis of CFRD. So that's actually quite significant. When there was also a very nice study looking at how lung function relationship to oral glucose tolerance status, and they found that after 4 years of having a baseline oral glucose tolerance test, those who had early CFRD, even with a normal FEV1, had the worst lung function versus those with an abnormal glucose tolerance versus those with a normal glucose tolerance. And this leads to an increase in acute pulmonary infectious exacerbations and worsening overall prognosis for the patients. So how does this work? What is the mechanism of action? One of the first thought is that insulin insufficiency results in a catabolic state. So if we look at how normal physiology of insulin, it affects the muscle, skeletal muscle, liver, and adipose tissue, and leads to an increase in protein synthesis, increase in glycogenesis, increase in adipogenesis. And overall, if we look at the tissue metabolic spectrum, it's more into an anabolic state because it leads to tissue buildup. So you can assume that if you have a low insulin or decrease in insulin, then this will shift towards more of a catabolic state and with tissue breakdown. And in fact, it does lead to excessive protein and fat breakdown as well as significant weight loss. What is well established in our CF patients is that a decreased lean body mass is associated with increased risk of death. And in fact, in patients with CFRD, low BMI is more prevalent in all age groups. It was even found in patients with impaired glucose tolerance or INDET, and these are actually found to have worse pulmonary and nutritional status. And that's why the mainstay therapy is insulin, because it reverses the chronic weight loss and helps maintain normal weight as well, which is paramount for our patients. A second well-established mechanism of action is that in CFRD is that hyperglycemia causes a pro-inflammatory state and an increase in oxidative stress. So through non-enzymatic Maillard reactions, hyperglycemia leads to what we call advanced glycation end products, which actually affects the beta cell and leads to further beta cell dysfunction. These receptors for age are also expressed in the lungs. And in fact, plasma levels of these end products or age were found to be 10% higher in patients with CFRD compared to those without CFRD. And when they correlated these levels with pulmonary function, there was a negative correlation. So this is quite significant. In fact, these end products also have a negative effect on the pancreatic beta cell, like I just suggested earlier, because it increases circulating cytokine concentrations, which leads to further DNA damage in beta cells and to further hyperglycemia. And this, for example, interleukin-1 beta was actually found to be in pancreatic autopsy samples from patients with CF. And so we think that this could also contribute to accelerated rate of beta cell loss in CFRD. Thirdly, another mechanism of action as well is that hyperglycemia causes a pro-infectious state. So bacteria and various pathogens thrive in a hyperglycemic environment. Glucose is not typically present in airway secretions, but was found to be high as above 144 milligram per deciliter in patients with CFRD. And that is why insulin replacement is the mainstay of treatment for CFRD, because it addresses both the protein catabolic state caused by insufficiency, as well as the pro-inflammatory, pro-infectious state caused by the hyperglycemia. So let's change gears and talk about CFRD and transplant prognosis. So lung transplantation is an accepted life-prolonging therapy for end-stage CF lung disease. 92% of solid organ transplant in CF are actually from lung transplants. Diabetes, in this case, can be categorized as either pre-existing before surgery or developing post-transplant. And I will discuss this in the next slides. There are a handful of cases where islet and pancreas were transplanted at the time of the lung and liver transplant, but these are rare and complex, and we don't have a lot of data on this. When it comes to pre-existing CFRD, it has been reported to be present in 29 to 65% of CF patients needing transplant. I'm not too surprised to see such high levels, such as 65, just because, as I mentioned earlier, how CFRD definitely impacts lung function. And and these patients are typically sicker and thus are more likely to need a transplant. Pre-existing diabetes has variously been described as either increasing risk of transplant morbidity and mortality or as having no effect. But what is well known is that the greater risk of death is in the 3 months of peri and post-transplant period, and it's usually related to infection, bleeding, and multi-organ failure. So typically, if they survive the first few months, mortality is likely no different than for CF patients without diabetes. And actually, in the long term, diabetes control may actually be better post-transplant because there is going to be less chronic lung infections and inflammation and reduced insulin resistance. Let's talk about post-transplant CFRD onset. This has been described to be present in 20 to 63% of patients who underwent transplant. And it could be related to several factors, including baseline beta cell dysfunction, post-operative stress, enteral nutrition, and beta cell toxic immunosuppressive therapy. And finally, I will talk briefly about CFTR modulators because we cannot have a talk about CF without discussing this. They have truly revolutionized the care of patients with cystic fibrosis. So it is well established that they improve FEV1 and reduce the number and severity of acute pulmonary exacerbations. And there are actually now small studies that were done showing a positive impact on insulin secretion, which could actually have a positive impact on CFRD as well, and profoundly reduce the risk of microvascular complication if that is true across the board. The concern, though, is that it might increase macrovascular complications because nowadays we're seeing more and more patients who are gaining weight on this medication and they're becoming overweight and obese, and they could have normalization of lipid levels or even higher lipid levels. And we could be seeing more metabolic diseases now that are also becoming so prevalent in the rest of the society. So in conclusion, diabetes has a negative impact on morbidity and mortality of all forms of diabetes, but also in CFRD. CFRD can lead to classic microvascular complications at a similar rate as type 1 and type 2, but the severity appears to be less. And annual screening is actually recommended starting 5 years post-diagnosis with CFRD and fasting hyperglycemia. Macrovascular complications remain rare, but is also being reported nowadays. Annual screening is only recommended for certain patients. CFRD has a negative impact on lung function and survival overall from pulmonary disease and cystic fibrosis. Modulators now, by near normalization of the CFTR function, may dramatically change the prognosis in CF. Most of this is expected to be for the good. So we're talking about better lung function, better nutrition, less inflammation, and longer survival. So it would be very interesting to do more studies like the one that I presented earlier on our patient with CFRD versus CF past 2012 to see what happened with that risk. And one thing that's important is that now with normalization of the weight and lipid pattern, we may be seeing more metabolic syndrome as well, and we need to be we'll need to watch this very carefully. So I would like to thank the Attain Health Summit organizers and donors for organizing this event, the Envision 2 group, and especially our mentors, my mentors, Dr. Antoinette Moran and Dr. Amir Mohit, as well as my colleagues, Dr. Swapnin Kaur and Dr. Farah Khan, who helped me work on the paper and the presentation. And I would like to thank the Cystic Fibrosis Foundation as well. Thank you.